Take it away, Amanda.
All right, so good afternoon, everyone. As you may know, my name is Amanda Feliciano. I'm a fourth year medical student. I want to introduce today our guest physician, Dr. Chirag Patel. He is a PGY4 OB-GYN chief resident, trained at McLaren Macomb Hospital and graduated from UMHS. He is currently a member and treasurer of the resident council, and his hobbies include exercising regularly and caring for his many pets. Thanks for being with us today, Chirag.
Absolutely.
Okay, you can move on. So, as we mentioned before we get started into today's topic, it's meant to be like an interactive session. So please feel free to ask any questions, share your thoughts, or comment on anything that you guys may find interesting throughout my presentation. The topic today is rates of menstrual history taking and counseling with anti-cancer treatments are low, and people who menstruate deserve gender-specific care. Okay, you can move on. Okay, so for some background, the National Cancer Institute estimates that 5% of new cancer diagnoses occur in young adults between the ages of 15 to 39 years. In 2017, data found that 10% of females diagnosed with cancer were between the ages of 15 to 44 years. So why is that important? Basically, chemotherapy can predispose women to menstrual changes. And so women who are receiving chemotherapy can suffer from things like abnormal uterine bleeding that can potentially be life-threatening. It can damage ovaries and result ultimately in premature menopause. And so the purpose of the study was to explore the incidence of menstrual history taken, documentation, counseling, so much before, during, and after cancer treatment. You can pass the slide. For this study, there was a total of 964 female patients between the ages of 18 and 49 that were identified on searching for new appointments at a major tertiary hospital in Australia between 2017 and 2020. Of these 964 patients, there was 827 excluded because they were either managed at a different site, they received their initial diagnosis prior to 2017, or they just didn't have histologic confirmation of diagnosis, which left 137 patients, all self-reported females between the ages of 18 to 49. And so this paper basically reviewed the medical charts of these patients. Let's move on. The data that they collected from their charts were the primary diagnosis, the stage of cancer, treatments, menstrual disturbances, reproductive history that included like the menstrual history, the gravities and parities, and then whether there was any menstrual counseling or interventions offered. So for the purpose of the study, menstrual history taken was defined as monitoring periods and asking about the regularity and the features of their cycles. The study started with of course, patient characteristics. So again, we said that there was 137 patients that met the inclusion criteria. The age range was between 19 and 49, the median being 41. There was approximately, they found 1/4 of patients were documented as nulliparous, meaning that they never had a child. And there was approximately 1/4 patients that had no documented parity, or no, it wasn't documented whether they had children or not. They also identified the types of cancer that patients had. The most common type was breast cancer, with 54% of patients having that one. And then there was other ones like hematologic cancer, which 20% of patients had, GI cancer, 13%, and then others like head and neck, lung, melanoma, central nervous system, and gynecologic cancers. They talk about the type of treatments that patients received, most commonly being chemotherapy and surgery. And then they talk about also disease recurrence, whether their cancer recurred or not. Moving on, for menstrual history, there was 22 patients, or only 22 patients had their menstrual history taken during their first consultation with their managing medical oncologist or hematologist. And remembering there was a total of 137, so that makes 16% of patients. Furthermore, 68 patients had it documented at a later stage, and 12 had it documented by another health professional. So health professionals considered gynecologists, endocrinologists, or nursing staff. So there was a total of 102 patients ultimately that had their menstrual history taken at some point by a health professional, and then 35 or 25% of patients had no recorded information on their menstruation. They looked at some factors associated with the menstrual history taken. If we're looking at table 2, there's 4 different factors that they looked at. So they looked at cancer recurrence or progression, cancer type, age, and the number of children. What they determined based on this information is that breast cancer was associated with a menstrual history taken, where you see that the p-value was 0.001. But the other ones, the other 3 factors, the cancer recurrence, age, or number of children, were not statistically significant. Moving on to table 3. Before I start, I just wanted to recap, if you guys, anybody in the audience can define what does amenorrhea mean. You can either write it in the chat, or you can unmute yourself, or I can talk about it. All right, so let's recap. Amenorrhea basically means the absence of menstrual periods. Oligomenorrhea is abnormal menstruation that involves infrequent periods. Menorrhagia is heavy or prolonged menstrual periods. Dysmenorrhea is pain associated with menstruation. So I just wanted to recap those because they can get confusing. Okay, so going back to table 3, they talk about the documented menstrual disturbances. So from the people who did have a menstrual history taken, they found these 6 issues that were documented. And the most common one was treatment-induced amenorrhea, followed by menopause or menopausal symptoms, and lastly, iron deficiency. There was 18 of the patients, the 102 patients, that had no menstrual disturbance. We can see based on this table that they have also the intervention given. So even though treatment-induced amenorrhea was the most common menstrual disturbance seen in women, there was only 4 patients who received an intervention. And we can also see based on this table that menopause or menopausal symptoms and iron deficiency were more likely to be treated than any other of the disturbances.
Amanda, I have a question.
Yeah.
I apologize if this was answered in the article, but how long after treatment did they record all these symptoms?
Oh, it doesn't mention it in the article, and I'm not sure how long it takes. I do know that it would be the article talks about more how chemotherapy causes the menstrual disturbances. So I believe it would be more based on the patients who received chemotherapy versus the ones who did not. Because I think there was 90% of patients that received chemotherapy, so 10% didn't.
Okay, so it's more concurrently documenting symptoms as they're undergoing treatment, right?
Correct.
Oh, gotcha. All right, thanks.
Mm-hmm. Okay, we can move on to the next slide. Thank you. Okay, so based on the authors, they state that to the best of their knowledge, this is the first study that investigates this incident of menstrual history taking, counseling regarding menstrual care during cancer therapy, and the incidence of menstrual disturbances during the treatment. It found that 16% of patients had their menstrual history taken on the first consultation. 82% had a menstrual history documented, reported menstrual disturbance. In other words, they had some sort of menstrual disturbance documented. 18% who had their menstrual history documented were counseled on their disturbance at some point, and only 7% were counseled at the first visit. They found that a diagnosis of breast cancer was significantly associated with menstruation or menstrual history documentation. Let's move on. Okay, so again, menstruation, we know that it's a normal physiologic process that can be affected by chemotherapy. And even though menstruation and menstrual changes should be key elements of patient care, they really have been historically or negatively regarded. And these people who menstruate, they deserve, right, like gender-specific care, and therefore appropriate recognition of the disturbances in their menstrual patterns, which then may facilitate timely and specific medical management. So it's important for clinicians to understand like menstrual patterns of their patients at baseline, be able to differentiate between normal and abnormal menstruations, to then furthermore evaluate and treat their patients with cancers, menstrual changes. Discussing and documenting like their menstrual history early in cancer assessment is essential, because given the like cancer treatment implications on the patient's fertility and bleeding risk, and their psychosocial well-being. So basically, if treating physicians don't establish and document their patients' baseline menstruation patterns, including menopause, it can later become difficult to appropriately educate patients regarding when to seek help or identify the need for intervention. Treatment-induced, okay, yeah. No, I was just going to mention like treatment-induced amenorrhea, which was the most common complaint in the study they found. It can adversely like affect fertility and premature menopause, which can warrant like consideration for treatments such as hormone replacement therapy, calcium, bisphosphonates, vitamin D, or even exercise to like manage menopausal symptoms and negative like cardiovascular complications furthermore. Okay, we can move on to the limitations. So first, there was a retrospective study in Nature. So some of the challenges that lie in this retrospective nature can be like the definitions of the different terms we talked about earlier. So like what is oligomenorrhea, amenorrhea, dysmenorrhea, menorrhagia. The study was performed only in one single institution, and so studies can be explored across multiple centers and geographic locations. And then also like menstruation histories could have occurred, but just simply were not documented. Moving on, in conclusion, basically to sum up the study, we know menstruation disturbance is a common side effect of cancer treatment. And so the menstrual care should be essential to cancer care for people who menstruate. And this can be achieved through higher engagement of like education of medical staff, information technology systems, regular audits, better alliances between cancer fertility specialists, and finally, like the creation of accessible patient information to promote awareness and facilitate the discussion. All right, and then to tie it all together, I just added a couple slides of clinical correlates. So like here I talk about normal menstruation parameters. I found this chart on UpToDate. So like frequency is described as normal if it's between 24 and 38 days. And then abnormal would be no bleeding, frequent bleeding, or infrequent bleeding, described as either frequent being less than 24 days or infrequent more than 38 days. Duration, 8 days, less than 8 days is normal, more than 8 days is abnormal. regularity, basically a regular cycle, so can vary between 7 and 9 days. And then an irregular cycle would be like a longer variation, like more than 10 days. Volume, this one says patient considers normal, patient considers light or heavy. So this one is a little bit more tricky. But there is like a research number that determines what is a normal amount of bleeding, and that's less than 80 milliliters per menstrual cycle. So it's a little bit hard to calculate that, but there is like a number. Intermenstrual bleeding would be normal if there is none, so no bleeding between periods. And then it would be abnormal if there is random bleeding between periods, or predictable, whether it be early, mid, or late cycle. Unscheduled bleeding on contraceptives, for obviously if it's unscheduled bleeding, it would be, if there is unscheduled bleeding, it would be abnormal. So there is a little bit of that. Moving on to the last slide that I have here is just the chart of the menstrual cycle. We know it's divided into 2 phases, follicular and luteal. The follicular phase starts on the onset of menses and ends before the LH surge. And then the luteal phase follows. So it will start with the LH surge and end with menses. We can see in this chart like the ovarian cycle. So we see when ovulation occurs. We can see the body temperature, how it changes and increases right after ovulation. We can see the anterior pituitary hormones fluctuating throughout the menstrual cycle. So the blue representing the LH, where we can visibly see the LH surge, and then the yellow and the purple represent like estradiol or estrogen and progesterone, and we can see those fluctuating as well through the menstrual cycle. And that is it for me. These are my references. Thank you all so much for your attention. And is there any comments or questions?
Hi, Amanda. This is Alex, one of the board members for CRG. So one thing that stood out to me was that like huge number discrepancy at the beginning. So you said that they initially looked at like 900 something charts, and then only 100 something charts were included with documentation. And like, I know that you mentioned some of the limitations and some of the, suggestions they had for improvement, but I was wondering if the paper talks about any particular reasons why they thought this menstrual history wasn't being taken so often or not documented, or if you have any thoughts on like, barriers to taking history more regularly.
Yeah, so they do mention like how they think that menstrual history is currently not being taken. I think it was something they just kind of like, they described that many cancer physicians basically avoid the discussion about menstruation due to either feelings of discomfort or awkwardness, or also because their patients may have a poor prognosis. So it's just something that they noticed really was not being a part of men's or of women's or people who menstruates care. And so like they mentioned, this is the first study that involved that, and they wanted to also like promote more studies and more research like on this topic. If that answers your question, I'm not sure.
Yes, sorry. Yeah, I was kind of getting at, if they thought that it's more of a kind of cultural thing, like, rather than an educational thing, because I think we're all taught, hypothetically, these are the things you include in a history and a menstrual history, for example, but it seems like, a big barrier is more of the cultural, more uncomfortable part of talking about it, even though it's an important part of medical care for people who menstruate.
Right. And I feel like a lot of times people think that since it's menstruation, that maybe that just goes like for gynecologists to be talking about it, when in reality, like all different types of specialties should be focusing on this type of history for their patients, as it can, vary based on especially these cancer patients who are receiving chemotherapy, and they can, be experiencing these disturbances.
I think like another issue with that is like the time. Like whenever you're taking a patient's history, like especially as a student, the preceptor expects you to like be in and out in like 5 minutes. And you're like, how can you possibly ask all the relevant questions plus like specific questions about their period? Like I'm in OB right now, and like I barely get time to ask like how heavy is your flow? Like all those kind of questions. And it's like even in OB we don't get to it, you know what I mean? So it's like I
Yeah.
can see how it can get overlooked, but definitely shouldn't be.
Mm-hmm. Yeah,
Hey,
exactly.
Amanda.
Yeah, hey.
Sorry, I didn't mean to cut you off. This is Ananya. This isn't really like a question per se, but just something for like all of us to keep in mind too with this study is that this one was done in Australia, which, is great. It's still obviously very relevant to the rest of us, but like their racial background of their patients is going to be pretty different from what a lot of us are going to experience most likely. Most of us are going to be practicing in the US or in Canada, which are very diverse countries. So, and I think that one of the points that the article didn't really touch on that is something that we have to be aware of is that our patients are going to come from different like socioeconomic backgrounds and have different like racial barriers that we've all discussed before in terms of comfort level with physicians and access to healthcare, and that can also affect kind of the healthcare they're getting in terms of if they're even reporting their symptoms and if they're getting good healthcare in terms of addressing those things. So, obviously definitely important that we should all be educating ourselves on having these conversations with our patients, but also being aware that some patient populations are not going to come to you with these issues. So we have to kind of go after them a little bit more.
Yeah, that
Sorry,
is
that
correct.
was all I wanted to say.
No, yeah. I agree. That's correct. And some of these patients, like you were saying, come from different socioeconomic status. And so like maybe they don't really follow with the guideline colleges. So that's not going to be, a history that's been recorded in the past to someone else that you can reach out to that may have this information. So yeah, that's very important as well. Thank you for that.
Thank you for the talk.
All right. Well, I guess that's my part. Is there anything you want to chime in and comment about, Dr. Patel?
Yeah, I thought you did a great job, Amanda. It was a great presentation, and thank you for having me, everyone. I just wanted to kind of touch base on a little bit about what you guys were just asking about in terms of, the history taking and that stuff. And I, even as an OB resident now, going through the last 4 years, there are times when I feel like even as a provider, as you get more comfortable with interviewing patients for the first time and cruising through some of the more easy pertinent, it will become more easy as you keep it in mind to ask patients about some of these more sensitive topics. I know it's hard sometimes, even though I'm an OBGYN resident right now, to kind of push into the world of more personal questions with some of these patients. And I thought that the point made earlier with the fact that there's so much diversity here where we'll be practicing, that you almost have to kind of tune your conversation in specifically towards each ethnic background potentially or socioeconomic status point from each person. So as I feel like I've grown through the years, I've been able to quickly recognize when it's appropriate, how to make it more appropriate, and how to get these answers, like you guys are saying, that they're so crucial to understanding these patients' histories and medical standpoints. Because someone who has cancer, who is undergoing treatment for cancer, just because that's the situation doesn't necessarily mean it will be their situation forever. And that's going to be their only problem they experience throughout their lives. And it is important to have a documentation at some point to establish what could be potentially seen as normal and if it's changing to becoming abnormal. As everyone is different, it's important to get a good baseline for each patient. But I will say sometimes, even myself, I will forget to ask patients when their last menstrual period was, or something potentially related to their menstrual cycle. And just never feel afraid to go back and ask the patient, in your in your years of history taking and when you guys are on your own and things of that nature, it's never going to be the wrong thing to potentially go back and even call a patient and say, hey, I'm so sorry, but I forgot this question. Like, I really think that this is important for your medical history and in your documentation, so everybody knows, even though you're not their OBGYN or their primary provider. You know, you'll see as you read more and more charts and notes from specialists that some are very, very detailed and take notes that are just insanely helpful versus others that don't. And you're going to really quickly realize how much more beneficial it is to just have all of the pertinent details, whether you think they're pertinent or not, someone else may. And that's, I think, a big key factor when it comes to taking that history. But other than that, you know, I think it's a pretty quick, if you can kind of nail down your pertinence of what the questions are, you can kind of throw them out there in a nice succession and get like a 1 sentence answer. And that might give you a boatload of information to do stuff with. So I definitely agree. It's very important, easily missed, but something that if we just keep in the back of our minds with all these patients, I think we can really help them in the long run.
Yeah. Thank you so much for that.
Yeah, no problem.
Any other comments or questions? All right, well, that's it for me.
All right, thanks everyone. And if anyone here, I know there's a few people interested in OB that are here. If you guys have like even more general questions or like anything like that, Dr. Patel, if you're okay with answering that kind of thing, like you know, on like roads to get there and like how it's been so far in residency, and maybe tell us a bit about your experience just to give everybody like a little bit more of like a personal or what to expect kind of thing, you know, if you don't mind touching on
Yeah,
that.
yeah, absolutely. Absolutely. I don't mind at all. Does anyone have any questions before I just kind of give you guys my 2 cents about everything? But I'd like to hear if there are any questions out there. No? Okay. All right. Well, as you guys know, Amanda introduced me. I did go to UMHS. I graduated in 2019, and OBGYN was my primary choice here when it came to matching into residency. I did all my training here at McLaren, and you know, I've been fortunate enough to be in connection with Amanda to get on this group. But you know, over the past 3 to 4 years, I've noticed a huge difference in, you know, training and throughout the residencies. I think in general, um, you know, it's been a very different transition between pre-COVID, COVID, and now I would say like a post-COVID type of transition into residency from medical school. Um, I would say that, you know, specifically for me, one of my biggest uh, loves for this field was the multidisciplinary actions that we get to take as an OBGYN, and also just the avenues that you can go through and proceed to as you grow into your own physician outside of residency. There's a huge surgical aspect of this field that I think is highly desired from those who are looking for something surgical, but also not looking to just be a general surgeon dealing with bowel cases and some of those heftier cases that you may not actually be intending to want to do. When I first learned about OBGYN, it was in my in my third year rotation. So I had pretty much come into the rotation blind, and I thought that it was such an eye-opening experience. So for any of you guys who haven't done OB-GYN, I would definitely utilize that time to just see how, you know, your experience is. And I'll just kind of be general here, but every residency is going to be different across the board. Some people will get an experience that others may not get. Others may get a bad one, and others may get a good one. But at the end of the day, it's kind of just how and who the physician you want to be in practice like is. Knowing what your strengths and weaknesses are important in this field, definitely, because it is a lot of multidisciplinary actions, and that includes a lot of patient conversations. A lot of psych goes into this field. So if that's something you're trying to avoid, you know, it's going to be one of those struggles that you battle through until you figure out how to get out of that aspect. But, you know, I would say over my 3.5 years of being a resident, it's it's been wonderful. I mean, residency's hard no matter what. I'm sure you guys all know it's just a lot of work, a lot of reading, a lot of feeling like you're not really there doing, kind of the imposter syndrome type of feeling. But in due time, everybody advances. And at that point, you just work hard. I would say it's a field where, depending on your residency size, it's going to be one of your more highly sought after residencies with just as much work to follow. It's not necessarily an easy residency because it is 4 years. There's a lot of competition. And at that point, everyone's just kind of searching for the people who really want it. So I definitely just really push into the field and really show yourself or show the people that you're working with that you want this job, if that's kind of where you're leaning towards. But just so many different avenues, I think. And if anyone has anything specific they want to ask me about, I feel like I'm kind of just blabbing now. I'd definitely answer any questions if anyone has anything, or Amanda could probably give you guys my phone number if you guys just want to text me or give me a call and ask anything. I would say letters of recommendation are quite important, but now I'm so far out of the application process. I know that they have their own independent application system now, to get into the obstetrics. But at the same time, I don't think it's going to be much more different than, the past in terms of interviewing and, how they choose their candidates, etc. But but yeah, does anyone have any specific questions or anything that they were curious about?
I have like a more specific question on like the lifestyle. Like, are you like,
Yeah.
I feel like an OB is like always on call. Is that like a myth?
Yeah, so that's a great question, actually. I think that's something that, in my mind, I thought the same thing. But now, as private physician groups are getting more bought out by private groups or hospitals, the on-call consistency is more of like an old school thing. So if the fear of being on call is the concern, then there's always going to be an avenue to avoid that in terms of the practice or the group that you choose to go with. Now, some OB-GYNs finish residency and they go and they only work in the hospital. They manage the L&D floors, they manage the ER consults, but then after their shift is over, they leave. They're considered like the hospitalists, and they do all the deliveries. They can do pretty much anything a true obstetrician can do, but they don't have to go to clinic. They don't have to take on calls, come in for deliveries if they're not on shift. Now, the old school way was your patient, you come in whenever they're ready. And that was kind of how it has been. And even at my hospital, when I first started here, there was no group call. It was, if your patient's in labor, I'm calling that attending. If there's another patient in labor and she's ready to deliver, I'd call the other attending. So I'd have 3 or 4 different attendings here at one time just for their single patient. Now, in the 3 years that I've been at this hospital, they've actually made the attendings join a full on group. So now they have a group of 7, and I only call one physician for 7 different doctors' patients, which is just so much more facilitating to a real life. They can spend time with their families. They can split up the holiday coverages. They can split up the weekends. And, if events come up or things come up in life, like we know that they do, they have the ability to edit and not necessarily just leave their patient hanging with somebody who they don't trust. So now the groups are starting to get large. And I'll say that the group that I'm looking at is about 17 to 18 providers. So I plan on being on call maybe twice or 3 times a month at max. And that's kind of like, in my mind, what I see as reasonable. But everyone's a little different. Some people like I have to go in, rush in right away, and some people don't. So it will eventually be whatever your lifestyle is that suits you.
Gotcha. Thank you so much for that
Yeah.
that take. Does anybody else have any questions for Amanda or Dr. Patel? If not, we can proceed to just the next part of our meeting. And Dr. Patel, thank you so much for coming. If you ever come across any research and you need help, if you need hands, definitely reach out. You can reach out to Amanda, reach out to us. We'd love to work with you in the future.
Yeah, absolutely. I should be having something here in the next couple weeks that I'm working on here, so I might need some extra help. So I'll definitely let Amanda know. And again, thank you guys for having me. So I appreciate it. It was a really nice lecture. And again, if anybody has any questions that come up in the next, couple days, couple weeks, or whenever, and it regards, the process, help, questions, or just, curiosities, I'm always willing to try to help out my colleagues, because good doctors make better doctors. So that's the best way to go about it. So you guys have a good rest of your day, and good luck, everyone.
Thank you. Appreciate it. Have a good day.
Yeah, you
Yeah.
too. Bye bye.
Bye.